Good afternoon. I'm Emily Actor-Zandi, Vice President of Atlantic Live, the live journalism division of The Atlantic. And thank you for joining us today for our Atlantic Eventcast, Beyond Skin Deep. We all care about our skin. For many of us, sharing new skincare tips or the latest new skincare product we've discovered is a deeply ingrained social ritual, something that brings us closer together with our friends and family. But our skin isn't just something superficial. It's also our largest organ. And like any other organ, it can be affected by real diseases that can take a toll on our physical and mental health. Over the next hour and a half, we are going to dive below the surface and explore the big issues in skincare, the psychological repercussions of skin disease, the rise of the wellness industry, and of course, geographic and racial health disparities. Before we get started, I want to thank Pfizer for supporting the Atlantic's journalism today. And we want to remind our viewers that you can be a part of the conversation, at least from behind your computer screens. You can ask questions in the Q&A function on the bottom of your screen. Keep them short and on topic, and let us know where you are watching from. And now let's dive in. For our first session, I would like to introduce Melanie Knight, a patient who's here to tell her story. Melanie, the floor is yours.
My name is Melanie. I was diagnosed with psoriasis when I was 9 months old. Both of my parents have it, so they knew what it was early on, so I got my diagnosis pretty quickly. Growing up with a skin condition is a very different experience than being diagnosed with one later on in life. I didn't have this big change. I didn't have this mystery disease. It was just what my life was. It was always my life. I grew up with psoriasis covering 80% of my body. I had patches all over my arms and legs. I had spots on my face. Sometimes they would split open and bleed. Kids would stare, they would ask questions. Parents would assume that I had chicken pox or some other contagious disease. I was asked to leave pools. I was told to stay away from other kids so that they didn't catch what I had. I was told that I was disgusting, that nobody should touch me. Being a kid with a visible abnormality is really hard. It was hard for me. I didn't like that people stared at me. I didn't like to go to the pool because swimsuits showed more skin than regular clothes. I didn't like to use my topical steroids because they made my skin more red than usual. I didn't like using my light box because it left a smell on my skin that I thought everyone else would notice, even though it was only something that I could tell. I didn't like to be touched because people thought my skin was disgusting and contagious. But my parents raised me to be confident. They raised me to advocate for myself. I worked with the National Psoriasis Foundation. They made sure that I knew that I was unique. They made sure that I knew that I am perfect the way that I am. They taught me to inform those who ask me questions about what psoriasis is and how it affects me instead of just getting upset and embarrassed. Psoriasis is an autoimmune disorder as well as a skin disorder. It comes with a list of potential comorbidities so long, I can't even remember most of them. Because of this, I was a sick kid. I was sick all the time. I missed school. I was in the hospital a lot. I had to work hard to do just as well in school as other people, to keep up with my friends. And I did. I graduated with honors and I earned a scholarship to CU, but I never really got a day off. My disease progressed. I developed psoriatic arthritis. I was diagnosed with fibromyalgia. I have had stomach ulcers, gallbladder issues, chronic strep throat, chronic sinus infections, chronic migraines. The list goes on and on and on. I lived with crippling anxiety and depression. I had to start taking immunosuppressant medications, and I became immunocompromised. With the use of immunosuppressant medications, my skin cleared almost completely. If you looked at me today, you wouldn't even know. But because as the visible aspect of my disease faded, the invisible one got worse. I may not have the severe skin symptoms that I used to have, but I'm still affected by the symptoms of my disease and the consequences of a childhood riddled with doctor's appointments, medications, treatments, pain, embarrassment. Some of my doctors never really understood how my disease affected me outside of my physical symptoms. My primary care physician thought I was sensitive and that I tended to over-exaggerate when I spoke about what I was going through. I had to fight for myself at every single appointment with her. She even left a note in my chart that my mom found when I started to see a new rheumatologist about how I over exaggerated my symptoms. Her disregard for my pain prevented me from receiving treatments that could have improved my quality of life. Her quick judgment of me and the note that she left for other doctors resulted in issues with new doctors that lasted long after I stopped seeing her. She didn't listen to me, and because of that, other doctors didn't listen to me either. But I have had wonderful doctors. My current team is awesome, but it is really important for doctors, especially primary care doctors, to understand that skin conditions are whole body illnesses. They're not just rashes, they're not just one symptom. And those of us who live with these conditions deserve to be taken seriously by our doctors. My skin has both directly and indirectly affected my work, school, self-confidence. It's had impacts on my physical well-being, my mental well-being, and my social well-being. To successfully treat a skin condition, you can't just consider the physical well-being of the individual. You have to look at the whole picture. You have to listen to the patient. Take us seriously when we tell you something is wrong and that a treatment isn't working like it's used to. Consider the social and psychological impacts of the disease you're treating, and understand that we know our bodies. Just listen to us and hear what we're saying. Thank you.
Melanie, thank you so much for sharing your story with us. And to the audience, hello. My name is James Hamblin. I'm a staff writer here at The Atlantic. I read a column called Paging Dr. Hamblin, because that is my name. I've also recently published a book which is about skincare, the soap industry, and our ideas of cleanliness throughout history and cultures. And next up, we're going to be talking about treating the whole patient, which is a novel concept in medicine where you look beyond just the organ that as a specialist you're taking care of. In this case, we are focusing on the skin as a lens, but as we know, it is a lens into so much more, and cannot be treated in isolation. So without further ado, please welcome Dr. Rick Fried. He's a clinical psychologist and dermatologist, which is a fascinating combination that we'll want to get into at Yardley Dermatology Associates in Yardley, Pennsylvania. Dr. Fried, welcome to the program. I don't have Dr. Fried, but I will do a little bit of improvisational comedy in the interim. It seems like we're having some technical issues, so if everyone could please stand by, we will have him shortly. Ah, there he is.
Any better?
It's about 1,000% better.
Okay, good.
Hear and see.
As I was animating and mouthing with no volume, I just wanted to reach out to Melanie and thank her for such an eloquent, elegant, and just touching view of what psoriasis can be, what living with it can be, and sensitizing so many of us in a brief period about what it can be like to live with psoriasis, what people in their environment can be like, how cruel, intentionally or unintentionally, other people can be, and how deaf sometimes clinicians are. So thank you, Melanie.
Yeah, it's really, Melanie's story is a case for more clinicians thinking about mental health elements of skincare and dermatology. I was wondering if you could tell me just a little bit about how you came to that confluence of training and practice that seems, at least from where I'm sitting, like it should be more common than I believe it is.
I think the traditional medical model loves things that we can quantify. So when we saw a psoriasis patient, we can talk about the psoriasis area severity index, what percent of the skin is involved. And then we grade severity. And then when we treat, if it's a clinical study or in our office, we talk about percent improvement, physician global assessment. But none of that gets much beyond the epidermis and the dermis. The problem with feelings is they're hard to quantify. The problem with feelings is they frighten many clinicians, because if I open a Pandora's box if I ask Melanie how she feels, does it turn into a psychotherapy encounter of 35 minutes in a chair or a couch? And we know unequivocally now that psoriasis is associated with increased levels of depression, anxiety, social impairment, vocational impairment, sexual impairment. Not everyone by any means. Conversely, we know that stress and distress can worsen psoriasis. So if we don't address the psychosocial and intrapsychic, we're really not maximizing therapeutic outcomes. But I used to think I knew what a therapy session was. I thought it was a 15, 20, 45 minute encounter. What I now believe a therapy session is making a meaningful emotional connection with a patient and allowing them to understand that number one, we care. Number two, we understand.
That sounds wonderful. That can be easier said than done. I mean, I feel like a lot of clinicians feel like they're pressed for time, or feel like they can only do, what they can put in a chart, or what's billable, or what fits within this rubric of medicine. Does this require completely upending some sort of bigger paradigms about how we think of medicine, or could people, change their practices today?
Maybe this entire program should be called Unmasking Psoriasis, because I really think whether we're walking into an exam room, some of us 10 minutes after this with people with masks on, wondering what they're feeling. Specifically, I'll often say, or almost always say to psoriasis patients, is it tough to live with this? If it's a female patient, I'm more likely to get an honest answer. If it's a male patient, I'm less likely to get an honest answer. With a male patient, nah, doc, live with this for 20 years, same old, same old. I'll do what I call the 3-second eye test, where I'll hold eye contact with the male and say, honestly, Joe, how tough is it? When a guy holds eye contact a little bit longer with another guy, it's either a challenge for duel, a challenge for some other kind of provocative behavior. 9 out of 10 guys will try to shake off the tears, the head goes down, and they say, I hate it, it sucks. Women are often more forthcoming. So if I'll ask Melanie, honestly, how difficult is this? Often females will be very forthcoming and saying, I hate it. It enters and ruins many parts of my life. As soon as the emotional connection at that moment, that the physician cares enough, then 1 or 2 empathic statements. I take psoriasis enormously seriously. I promise you, we have the tools, and I will work with you to make psoriasis as least intrusive as is possible until the one person in the room who matters is happy. And that's not me, it's you. So 1 statement saying we care and we understand, 1 statement saying that their satisfaction is the most important thing. And that it's not a fixed target, it's a fluid target. And explaining that, you know what, psoriasis, one of the most terrible things about it is it pops up at the worst possible times. It's capricious. It does what it wants when it wants. If you've got a presentation, if you've got a date, if you've got a test next Friday, can anybody tell you whether it's going to be a good or a bad skin day? So I'll say, as a dermatologist, as a clinical psychologist, we're in the business of selling control. When people feel in control of their bodies, of their emotions, and their skin, they feel better in general. Good, effective psoriasis regimens give control, where it's not perfect, but the skin is much better behaved and more predictive in what it's going to do. And sometimes giving them an analogy. In some ways, psoriasis is like living with a drug addicted or alcoholic spouse. You never know what's going to walk through the door. Mm-hmm. And by being able to better predict that and better control that, the next thing, we will only offer you what I would offer to my own family member that I cared about. we think long and hard about the treatments that we recommend and that we offer. Last but not least, say to them, look, there's a lot of information out there. And you get on the internet, you look at textbooks, and you feel like it's just everywhere you turn, you're going to make a mistake. And that every one of these treatments we recommend have horrible possible side effects. And what I'll say to them is, look, anytime we touch anything, anytime we take a gummy bear vitamin, anytime we eat a shrimp, anytime we put a new cream over the counter on our face, we could have an adverse reaction. So what we do is we look at all the things that could be bad about a treatment. And then we put a giant comma after that. And we say, well, what are all the bad things that could happen if I don't take this treatment? Then we flip it and say, what are all the good things that can be in front of us? Good psoriasis treatment is liberating. And I want to let you ask your question, but I do want to get to something called subclinical depression. So I'll shut up for a minute.
And I should say also, you're referring to Melanie's case with psoriasis, but a lot of what you're saying sounds like it's extrapolatable to acne and eczema too, in terms of lack of predictability, lack of control, overwhelming sources of information. It seems like everyone is an expert, everyone is a guru who has Instagram and can start a skincare line.
Absolutely.
This is something I got pretty deep into this world when reporting my book, and I know how people go into these spirals of trying jumping from product to product and not knowing who to believe and who to trust, and that cycle of feeling out of control and just trying to establish some sense of control. How do people do that in a disease, like you said, that's diseases that kind of fluctuate, that come and go, that necessarily we're not able as medical professionals to completely get rid of this permanently, in a way that for a lot of other medical specialties, that's more what it's about. It's a permanent eradication.
Right. Now, with the newer medicines and newer guidelines for the National Psoriasis Foundation, we are shooting for 100% clearance. So sometimes we do, in fact, get rid of all of it. In terms of understanding the impact on the patient, a long time ago in a faraway place, I used to be in charge of an inpatient adolescent program for drug and alcohol abuse. And one of the things we'd always ask is, tell me something before you got very heavily involved with whatever substance you're using. What'd you do for fun? And they say, well, I like tennis, I like touch football, I used to go to the beach, I used to do this, I used to do that. Terrific. The last 6 months before you came into treatment, what'd you do for fun? There's often a deer in the headlights stare that's a sudden awareness. I haven't done anything except thought about where my next hit was going to come from. Psoriasis, acne, rosacea, eczema, they can all very insidiously take away our range of happiness and activities. And it's not until they realize how much they've given up or how much psoriasis has stolen from them that they really say, hey, I need to trust somebody. Relationship is everything. And forming enough of relationships that they can trust us, I think, is our primary obligation. Again, reassuring them that they, in fact, can trust us and we make decisions on their best behalf. I talked about subclinical depression. When we look and try to assess, are they depressed because of their psoriasis? We look for the classic things. Are they sleeping? Are they eating? Are they able to smile, able to hold eye contact? Subclinical depression, people can do all that. They can tell jokes, listen to jokes, laugh appropriately. But the shine on so many things is gone. They don't feel as happy. Flowers don't smell as good. Food doesn't taste as good. Sex doesn't feel as good if, in fact, they are intimate. And they don't realize it. We don't realize it. So saying to people, I want to give you back your freedom. I want your skin to feel right again. It's underestimated how sensory changes burden so many people with psoriasis. Melanie made reference to the emotional that carried forward. There's something I call phantom psoriasis and phantom acne. People can be free of any disease for 5 years, but when someone goes to touch them, still experience life as if they have a plaque there. So we have never been at a more able, more educated, more empowered way to bring people through the psoriasis process. I'll also say that what ifs, one of the things that happens when people start to get better, they often out loud or in the middle of the night think to themselves, well, what if this medicine stops working? Is this just a cruel tease? Am I going to go back even more disenchanted and more disheartened? So I always make clear that we have an enormously deep tool bag. And if this medicine stops working as well as you'd like, we'll move to the next one and yet the next one, that we never were going to run out of things. Last but not least, trust.
Oh, I have so many questions that I want to ask you.
Go ahead. I'll shut up. Go ahead.
Well, I think we only have, I only have time for one more. So as concisely as possible, there's this panoply of products that are available to people now and information. And people are buying lots of expensive skincare products. In some ways, I understand it to be good because people are empowered and there are lower barriers to entry for innovation in the market. In other ways, there's not a lot of transparency. Consumers don't know what they're getting. They don't know who to trust. Should there be more regulation in the skincare market?
Yes, especially in claims of efficacy. You and I, or Melanie and I, could open Wonder Skincare Company. As long as I don't identify myself as a medical professor and she doesn't, then we can claim anything. And it leaves people so misled. I used this cream for 3 days and all my psoriasis went away. Absurd, absurd. So saying to people, you know what, using something that we've gone through hoops to show is safe and effective. I can't guarantee you there's not a magic cream out there, but the path getting there can lead to so many mishaps and some of them dangerous mishaps. Please trust me. Please trust me.
Well, I think that's probably why it's so important now more than ever that people have sort of docents or guides through this like menagerie of information. So thank you for the work that you do, Dr. Fried. Dr. Rick Fried, psychologist and dermatologist, joining us from Yardley, Pennsylvania. We'll leave it there, but thank you so much for your time.
Thank you so much for having me.
And now I am going to toss things back to the Atlantic's Emily Actor-Zandy. Emily?
Thanks, Jim, and thanks, Rick, as well. And now let's go to a session produced by our underwriter, Pfizer.
Hello, everyone. My name's Richard Blackburn, and I'm Global President of Inflammation and Immunology at Pfizer. And I want to start by thanking you for joining us on World Atopic Eczema Day. So today we want to raise awareness of the challenges that are faced by people living with atopic eczema and really recognize the resilience that they show each day. Because as you all know, eczema is so much more than just a rash. Every patient experiences it differently, how much they itch, how much it hurts, how much sleep they lose, or how the appearance of their skin affects their confidence and attitude. For some, the burden of eczema can be even greater, depending on their race or where they live. For instance, we've seen that children of color in the US tend to have more severe eczema than white children. And despite this, they receive relatively less care, and that's not right. So there's a real need to continue to sustain work to alleviate the burdens that chronic skin conditions have on patients and also reduce the associated stigma, empowering those living with these conditions to speak up and have their needs addressed. And that's even more true during an ongoing pandemic, which, as we all now realize, can complicate care. Now, we at Pfizer are proud to support efforts to ensure that the needs of the patients are fully reflected in the development of new medicines, especially for a condition like eczema. And to that end, it's such an honor to be here and a privilege to be joined by Wendy Smith-Begolka from the National Eczema Association. Now, as Vice President of Scientific and Clinical Affairs, Wendy plays a key role at NEA, guiding the evolution and growth of their scientific efforts and research across the organization. So welcome, Wendy, and thanks for being here today.
Thank you, Richard. It's my pleasure to be here.
Great. So we're going to discuss eczema's impact and how we can work together to improve and address some of the challenges that are faced by patients. And I thought to start with, maybe you could just talk a little bit about eczema and your organization's goals to support patients.
Sure, happy to do that. And I think your introduction teed it up really well, but just as a preface for those who might not know that are watching, so atopic eczema or atopic dermatitis, as we also refer to it, is a chronic inflammatory skin disease that really has two hallmark symptoms. It has itch and then an inflamed rash. And many people actually know it more commonly as the itch that rashes. And so what we also know is that it's a really common disease. Current estimates are that about 1 in 10 individuals are affected over their lifetime, possibly even more. And the other thing that we can also appreciate is that prevalence might tend to peak early in childhood, but this is certainly a disease that can affect anybody at any age. And you also alluded already to any race as well. So it's an equal opportunity disease, so to speak. And what we also know from dealing with patients and caregivers every day is that there is such a wide spectrum of disease severity and impact on life. It can range from quite mild to quite severe. But because most people are probably more familiar with the milder form, eczema as a whole, atopic eczema as a whole, is very poorly misunderstood and misconstrued as just a skin condition. And so at the National Eczema Association, we really see it as our goal to unhide eczema, really showcase the complexity, the diversity, and the severity and seriousness of the disease that it actually is, to help people deal with the isolation that can often accompany it, but ultimately to help empower patients to deal with every aspect of the very real struggle that they face, not only each day, but over the course of a lifetime.
And you know, to that end, the theme of this year's World Atopic Eczema Day actually focuses on raising awareness of the kind of serious daily impact that the disease has on patients and their families. Maybe you can tell us a little bit more about the psychosocial, those unseen symptoms that impact the patient experience.
The true burden of atopic dermatitis is so far-reaching, and much of it is often hidden from view, as you said. We know eczema patients deal a lot with itch. You also mentioned skin pain in your introductory comments. Sleep loss is a big one as well. But you don't necessarily appreciate that those things are happening to someone unless you visibly see someone scratching or they tell you that they had a bad night's sleep. But I'm sure you can imagine that the cumulative effect of all of those has an incredible psychological toll, an emotional toll, has impacts on your ability to focus and get on with other aspects of your life. And so a lot of these things, just compound the symptoms that they're dealing with. It can lead to anxiety and even depression in some individuals. And current estimates are that about half of patients that have atopic dermatitis have exhibited either anxiety or depression symptoms and are not being treated for that. And so that's quite significant too. And then related to just the life choices, there's a lot of decisions that people make because they have their eczema about what they will do and about what they won't do in their life. And so these are very significant decisions that they either make on behalf of themselves or for their family, related to career, going to school, picking different social activities. And for children, that's especially important because sometimes they can have consequences related to bullying because of their disease. The consequences of all of this put together is that all of these unseen considerations just really add such a layer of complexity to what is already a very difficult disease to manage.
Wow, there's so much there. And, as you said, for some people who don't really understand eczema, they will still say, it's just a rash. It's so much more than that. I'd love to know if there's a particular patient or story that, was kind of your aha moment that changed your understanding of this disease.
Every patient actually enhances my knowledge and understanding of the disease, but there is a particular day for me that actually stands out, and that was actually last year at a patient-focused drug development meeting that Nia, along with 4 other organizations, held with the FDA to really talk about what it is like to live with eczema day in and day out. And it was eye-opening. And what struck me as a common theme across all that testimony, you already mentioned resilience, that was one of them. But the other thing that struck me is just how atopic dermatitis, there isn't an aspect of their life that isn't touched by it. You know, from the minute they wake up to the minute they go to sleep at night, it's the clothes they wear, what they eat, how it affects their personal relationships, how much time they have to do what they want to do with their life as opposed to managing their disease, work, school, finances, and the list goes on and on. It's overwhelming on some level. And just listening to you speak, it also reminds me about, how crises like the current COVID-19 pandemic, that they act, I guess, as an additional stressor for some patients as well. There's no doubt that the stresses of worrying about the virus, about, changed habits, more frequent hand washing, they all combine to make life harder still for many sufferers, I should imagine. So finally, let's talk just for a moment about how advocacy groups and industry can maybe work together to help patients. Coming back to the idea that that meeting we talked about last year, patient-focused drug development, there was a spirit of collaboration in that meeting with the idea that some of the issues that we face right now may be issues that if we all work collaboratively, whether it's patient advocacy organizations with industry or even across industry or even across other disease spaces, there's a lot to learn from other chronic diseases. And then lastly, as we continue to move forward, it really is just all about keeping patients engaged in this process, inviting them into the conversation. This is such an exciting time for eczema research and for potential new therapies. And what that means for care. And so it's important to be sure that we're making this progress with patients as partners in this journey. Thanks, Wendy. Yeah, I guess as with all change efforts, collaboration is the key. So look, Wendy, our time is short. I'd just really like to say thank you to you and to the NEA and the other advocacy organizations for really all the amazing work that you do. And to all of you here with us, as we heard from today's discussion, let's remember that chronic skin conditions are debilitating, they're disfiguring, they're distressing, and they deeply affect what people can do each day. And at Pfizer, we feel an urgency to transform our science into potential breakthroughs that will enable freedom from that day-to-day suffering that these patients experience. And in order to truly make a difference in the lives of patients, we're going to continue to support the community and bring our scientific innovation forward. So thank you again to the Atlantic and all of the panelists participating in this important event. Thanks very much.
Hi, everyone. I'm Susan Saulney, journalist and Atlantic Live contributor. We're going to shift gears now and talk about rural communities, disparities, and skin disease. We know that many Americans outside of urban areas have very limited access to doctors in general, specialists in particular. So joining us to talk about this are 2 people who are trying to fix things. That's Dr. Adam Byrd, Associate Professor of Dermatology at the University of Mississippi Medical Center, and Dr. Sancy Leachman, Professor of Dermatology at Oregon Health and Science University and Director of the Knight Cancer Institute. Thank you both for being here.
Hey, good afternoon. Thanks for having me.
Thanks very much.
Dr. Byrd, let's start with you. After graduating West Point Medical School, you could have gone anywhere in the world, but you chose to open your dermatology practice in the small Mississippi town where you grew up. Can you tell us why that was important to you and tell us a little bit about your patients there?
Sure. My career path changed a couple times over, my 40 years. But one thing that never changes, I always wanted to live back in my hometown. So the town I'm practicing now is my hometown. So it's no secret that there's a draw that some people have to live around family and old friends. And I just had a great childhood. And always wanted to come back here. Medicine was the third of my careers. What was your second question?
Tell us a little bit about your patients, the people you see there in Mississippi.
Yeah, well, I have a wonderful job. I practice with the University of Mississippi, so I have the support of one of the largest employers in the state. Very large organization based down in Jackson, which is about an hour and a half southwest of us. But yet I work in my hometown, a town of about 6,900 people in a county of about 16 or 17,000. And I'm the only physician in the office. So it feels like private practice, although I have the support of the university. So the employee takes care of all of our billing and our staffing and taking care of all of our infrastructure. And I get to be released just to practice medicine. You asked about my patients. I think that my patients in a rural area are the same as they are anywhere else. Being in Mississippi, I'd say the overwhelming majority of our patients are blue collar patients. And some of them are in the lower echelons. But the type of skin disease they have is the same you're going to run into in Seattle or Washington, D.C. or anywhere else. Certainly a lot of psoriasis, like Ms. Melanie had earlier today. Tons of eczema, as we were just talking about. I guess one difference between me and other dermatologists, we don't do a lot of cosmetics. I mean, I do offer cosmetics. We try to be kind of a family dermatology clinic. We try to take care of everything from birth until death, and cosmetics is a part of that. But in my community, there's not a lot of demand for cosmetics, I guess. So that might be the only difference.
Your arrival there must have been life-changing for some patients, though. Would that be fair to say?
I don't know about that. So it was really neat. One cool thing about working for the university is we take all insurance forms. So we take Medicare and Medicaid and all of the managed insurance plans. We also take TRICARE, so we see people from the military. And the patients that we take care of now, they could have seen another dermatologist, but they would have to drive much, much further. So if they lived in Starkville, Mississippi, and they had Medicaid, before I came here, they would have to drive 2 hours to see a dermatologist, and they'd have to go to Jackson, and the lines down there are much longer. And now they can come 30 minutes to come to Louisville. Some people from North Mississippi were going to Memphis or Birmingham to get skincare. And so what we were finding is that their primary care doctors and pediatricians and nurse practitioners were trying the best they could to manage their disease. Now there's just somebody closer. So they had access. It was just poor access. Right. We work hard for our patients. We have a wonderful staff at our clinic. I do feel like we've had a positive impact on a lot of people's lives, but I'm not sure that's unique to us. I mean, all doctors are going to, make a difference in people's lives, and we're no different. But I think that people are driving a shorter distance now that we're here.
Dr. Leachman is making those changes too. Doctor, you pioneered an app called the Mole Mapper. I'm trying to get that into the hands of more people because you understand that early detection is key, especially if we're talking about melanoma. So can you tell us about your experience working with underserved populations and how we might get more American?
I'm sorry, I couldn't quite understand the last part of your question. How we might get what?
More rural Americans.
Yeah, it is a real problem. I think, a lot of times people don't appreciate that, that difference between access in rural areas versus urban areas. There's a true disparity between those areas. And one of the things that's pretty exciting that's on the horizon now is the use of telederm. And, we have all of the horrible things that we've thought about COVID and all of the crisis that has been created around that. But one of the silver linings of that dark cloud is that we've learned how to do teledermatology a lot better. And so Mole Mapper, which you asked about, Mole Mapper is an app that you can download for free from the App Store. It's only on iPhones though, so it is limited to people who have iPhones. But you download it and you can track your own moles. So you can see that one of the most important elements of a mole turning into a melanoma is change. And so if you're taking a picture of it every month and you're comparing it to your own, what it looked like before, that can give you a heads up that something's wrong and that you really need to get in. And having that documentation can help you get into a dermatologist more quickly, because they can have the proof that there's actually something that's going on. And so it sort of shortcuts your time in to see the physician as well and proves that you've got something. But it's not just mole mapper, it's all of teledermatology. If you think it's revolutionizing things, right?
Would it be safe to say that telemedicine is here to stay in dermatology, even in the post-COVID world?
Can I come in on that?
Sure. Sure.
I would like to offer a difference of opinion on teledermatology. I too got to experience that during the height of the COVID, and I agree that it might be better than nothing. It is certainly leaves a lot to be desired in my experience. So I think that in a lot of our circles, a lot of the people that are panelists here, we all have one of these, but it is not a valid assumption that all of our patients do. And even if they have a great iPhone number 11 or whatever the latest is, they may not have good service at their house, or they may not have reliable Wi-Fi, or they may have kids running around the room. So when we went through teledermatology, what I experienced was people calling me from their car and trying to show me their rash with moving the seatbelt and stuff like that. I found a lot of poor lighting. I found a lot of disconnections. I found that I could use Apple FaceTime with some people, but other people had an Android, and so I had to use Facebook Messenger. And the State Board of Mississippi fortunately released us to use those non-medical applications to do COVID, because they realized
Well, there's still some distance to be covered there, but I'm glad you brought it
and
up.
also the reimbursement. Another thing needs to be readdressed is, and maybe Dr. Leachman knows more about this, but I was told that the reimbursement for Medicare, Medicaid, Blue Cross Blue Shield for a teledermatology visit was something like 20% of a regular office visit, but yet the visit takes not only just as long, but maybe even longer, because you have to connect with the patient, and you have to deal with this a slower visit. So all of this, it requires more infrastructure, more laptops and cameras and things. So the reimbursement's not there yet. So I think it's better than nothing, but I don't think we can overstate. I think we can overstate how perfect it is. It's not there yet.
We know that poverty is high in some parts of medically underserved America. Do you think there may be some stigma running below the surface that dermatology is something for the elite, it's for the 1%? And what else should we be thinking about, paying attention to, as we try to address health disparities in rural communities?
Can you hear me?
Okay, yes.
So I think that it's a fair statement that there is a lot of poverty, and that poverty does affect the access that people have to dermatology in particular. If you think about it, it's sort of partly a creation of our own making, in that, there's a lot of cosmetics associated with dermatology. And of course, if you're struggling to put food on the table, the last thing that you're really going to be able to afford is something that has to do with cosmetics. And so because there's such of a framework thinking about the cosmetic aspect of dermatology, which is different than what we're talking about today, right? These chronic illnesses are very different. They are not cosmetic, and they do deserve to be available to absolutely everyone who's being negatively impacted by that. So I do think that we do need to change that perception, and to make an effort to be available for medical dermatology and surgical dermatology for cancers and things like that are clearly not cosmetic in nature. And so I think you make a really good point, Susan.
Dr. Byrd, in terms of the health disparity, poverty, race, do you have any other thoughts about how those issues should be addressed as we think about trying to fix them?
Well, it's a complex problem, and you already knew that. One of my I've been trying to recruit physicians to this town that I live in for now 5 or 6 years. And I'm not talking about dermatologists. I also work part-time at a rural hospital, doing hospital care, pneumonia, COVID, heart failure, all that other stuff. And we have had a real hard time recruiting family physicians to our town. And I believe one of the answers is in retaining and training and recruiting people that are from this town to go off to go to college, support them through college and medical school, and then encourage them to come back. Because I believe with small towns, people are more likely to want to work here if they are from here, they're familiar with it. More often than not, people that are from a large area, a large metropolitan area, aren't going to pick Louisville, Mississippi to set up practice. And they've never heard of Louisville. But somebody who's from Louisville or immediately next door, if we identify them early as somebody who has potential to go to medical school and say, hey, look, we'll help you with some of your student loans. We'll help you with your rent. We'll help you with your electric bill. If you'll come back here and work. I think that's a much more efficient way to recruit physicians here. Telemedicine is part of the solution. And there are some, I think some political, I'm aware of some discrimination that's happened in the telecommunications industry about not serving some areas well with cell service. Certainly, we need to have good infrastructure with our telecommunications so that people can have access to teledermatology and other telemedicine.
Right.
Other than that, I don't have any. And another thing is, at the University of Mississippi, we're starting something called a rural dermatology track. So what we've done is, like I said, I'm on faculty with the university, and we have recruited now, I believe, 5 residents that come work with me in rural Mississippi, and the university is going to give them a job afterwards, and in exchange for us training them in dermatology and letting them sit for the dermatology board, they have to go work in a underserved area of Mississippi for, I believe, 3 years following graduation. So we recruit them on the early end. We say, look, we want to make you a dermatologist, but you got to work for us for at least 3 years in a rural, underserved area. And so far, we've got 5 of those that are going to go out and practice in rural Mississippi. So part of it's educating dermatologists as well.
That's a great idea. That sounds so excellent.
Mm-hmm.
My next question would be about, I guess, educating the public. Do you think that most people understand what's at stake if they don't get care, if they don't early care, because that's the key to survival, particularly for melanoma? Do you think that there's a good understanding of that in the public?
Yeah, I think we know that they don't understand in the case of melanoma. It's a very common misconception that it's just skin cancer, and that most of the people that they know have survived skin cancer and just got it cut out, and there's fear about if it's on their face or somewhere that they can see that it's going to be disfiguring. And so there's all kinds of reasons that people choose not to get care early when it comes to melanoma, and it's tragic. It's really tragic because it's the one skin cancer that you can see it, it's there. You should be able to get in quickly, get it taken care of, and if you do, it's almost always treatable. If you delay, then it's late, and you are almost certain to succumb. The treatments are much, much better now than they used to be. But even with the better treatments we have, the 5-year mortality, in other words, how many people are left alive after, is less than half of the people, right? So it's a big difference. And that's where telehealth actually can also come into play, right? Where we can get people in, we can pay attention, and we can communicate better through all kinds of media and marketing to health promotion, right? I mean, we've been using health marketing to sell people cars that they don't need for years. Why can't we sell people the idea of taking care of themselves? That's what we should be doing. And when you can get access, when you can really get access to the people that need it the most over a short period of time, it's great. But I think your point, I just want to come back. We've been trying very hard to get dermatologists to be interested in going into rural areas. and using the telecommunication as a way to keep them in touch with the home base. And it's just not as easy as you think, because most dermatologists, by the time they get through with their education, they want to have a robust practice in a place that they enjoy living. And very few of them came from a rural background, as Dr. Byrd mentioned.
Mm-hmm. Oh, we have a quick question from the audience. It's for Dr. Byrd about the program you mentioned. Do many medical schools offer programs like that, or is the University of Mississippi one of the first?
Oh, I think we're one of the first. I know my boss, Dr. Brodell, got the idea from Loma Linda, which is in California. And if I understood correctly, and I'm not sure they even have that program anymore, but Loma Linda was doing a similar thing. They were training people, I think, in rural Michigan through the University of Loma Linda, and then they were going out and practicing in a rural area. Do other places have this? No, I don't know. And I tell you what, the ones that do probably don't advertise it on their website very well. We published a paper out of our university talking about website usage amongst universities. But we do have this program in Mississippi. And now one of the challenges is now that we've got 5 residents that are going to go out and practice, well, that's 5 clinics we have to open up. Okay, so in 2022, there's got to be another guy graduating, and we've got to actually build him a building and hire nurses and get computers and all that other stuff. And then in 2023, there's going to be another one. So this is one of the challenges that we're trying to work through. Certainly at the University of Mississippi, one thing that we might be able to do is work with other states. So let's say somebody comes to us from rural Arkansas. Maybe we work out an arrangement where their community pays for their residency education, and then when they finish in Mississippi, they go back to Arkansas, something like that. We'd be interested in doing something like that. No, but I think it's a new idea.
Yeah, good possibilities. So thank you, Jocelyn from Maryland, for that question. The good news is the number of dermatologists is rising nationwide. That figure is going up, right? It's just not going up necessarily in areas outside of cities. So there's some reason to be hopeful here that we can get some of those folks to move to underserved communities. Well, Dr. Byrd, Dr. Leachman, I thank you. I think that's a wrap. Thank you very much for joining us today. And Jim, I'm going to send things back over to you.
Thank you, guys. Thank you very much.
Thanks so much, Susan. And now we're going to turn to another sort of disparity, racial inequities, which manifest in dermatology in fascinating and very important ways, in ways that I think many people are not enough aware of. But one person who is a dermatologist, Dr. Lynn McKinley-Grant. She is going to be gracing us with her presence today. She's an associate professor at Howard and president of the Skin of Color Society. Dr. McKinley-Grant, thank you so much for being here.
Great, it's great to be here. And I wanted to thank Melanie and for her openness about psoriasis and the pain, because we believe in treating the whole patient also. What Dr. Leachman and Byrd and Dr. Freed in terms of working in rural areas and the health disparities that exist there, we find many of the same ones in Washington, D.C., where we have a very large underserved population. And the telehealth, we had exactly those same problems. That has started making, to me, I realized that internet has now become it's almost like a right. It's a public utility. It's as important as water and electricity, to get your health care. So I wanted those things were just so important to bring up in terms of health disparities, because of course they happen no matter what color you are. I think there are issues with underserved people that are underrepresented minorities too, and those come in terms of diagnosing disease. I think that's one of the areas where we have a large amount of health disparities of recognizing disease in people of color.
That's exactly what I wanted to ask you about. I saw you quoted in a story that was referencing a New England Journal of Medicine study about COVID toes, which, if anybody is not familiar, I mean, probably all are, but you get sensations and there's often a rash that appears on the toes. And the article is noting that all those images are on light colored skin, almost all of them in the textbooks and medical journals, and almost none on darker colored skin. And that actually manifests in ways where people with darker colored skin would be less likely to be diagnosed, or clinicians would not be used to recognizing that diagnosis. And in fact, that's a problem across dermatology, right? Not just for COVID toes, but for all sorts of things. Textbooks have been skewed with a wider bias toward just the basic diagramming and imagery. Can you give us some other examples of ways in which that sort of bias in training is manifesting as, actual tangible different outcomes for people's health?
So the COVID toes is an interesting phenomena, though, also because we really don't know for sure whether it occurs in darker skin types also. It's an immune reaction to COVID. Not many people who, they might be COVID positive, but they usually don't have the severe symptoms of COVID. So that's still out whether there's a shortage of it. I mean, there aren't enough images of it, but we're not sure how many patients exist. And that's really being looked at, of who actually had COVID toes at the time they had COVID. Usually it's exposure after. But I think in terms of diagnosing skin of color, I always think of the skin is really, as everyone has said, the largest organ in the body. And it really reflects every organ in your body. I mean, of health and disease. And you can tell, just like every mother can tell whether their child is pale, whether they're white skin or very, very dark brown skin. The mother, the fathers, in some cases is what the fathers do, can tell that the child is pale. And often and that often means the child might be anemic, the child might be, or the person might be anemic, the person that they're close to. So this needs to be transmitted to dermatology and to medicine, period, because the dermatologists train all the medical doctors in looking at the skin. And for everyone, every physician, the skin color is sort of the first thing you see. And then you see a human that's that skin color. So the other serious area is redness on the skin, which often is very hard. People say it's hard to detect because they're not trained in it, and detecting erythema in dark skin, but that's a different color. And erythema is always, it's a process. It's not just a color of change. So the erythema really depends on the depth of the lesion. As we know as dermatologists, if it's deeper in the skin, it's going to appear more purple. If you have more melanin in your skin, that same redness is going to appear purple. It's not going to be a bright pink. So these are very life-threatening things. And there are other signs of the skin. If it's yellow, then you have liver disease. If it's kind of a gray, you've got, you might have kidney disease. So rashes can appear in patterns, but the color is really the clue to making the diagnosis. And you have to be trained. Also, I see skin as a vital sign because you have to do everything. You have to touch the patient to feel the temperature. You have to touch the patient to feel the rash, if it's going to be a rash. You touch the patient to get the pulse. The respiratory rates, you look at how the skin moves to get that. So it should be almost a vital sign, along with the heart rate and respiratory rate. But it's very important if you can, to get the training in skin of color, but primarily because it's really a science now. It's colorimetry, chromatics, whatever you want to, the science of color. And it's affecting diagnoses. And as we are treating more people with the computer, it's a different color. The colors are different on the computer. I don't know if you remember that Academy Awards, and the one people said dresses were gold and white, and the other half says blue and black. And that really turned out to be kind of related to the browser, and I don't even know what the actual color was, but the actual color was whatever people see.
It was blue and yellow.
So we have a whole nother science that we have to develop, especially as we look towards artificial intelligence. You know, you're going to need to know the background color of skins. There are some artists who are working with that also, and what's in the skin, how much blood is in the skin, how much oxygen is in the skin. All of these things affect the disease and diagnosing the disease.
So there are some major, huge problems here that are complex and difficult and involve physics, but at a fundamental level, they involve culture and open-mindedness and progress and inclusion. And so as I understand it, your society is working to take basic steps to make progress toward inclusivity in dermatology, both for patients and for doctors. Yeah. What are you most excited about in terms of your work right now?
Well, I think in terms of our work, it's been going on for a while, but I think an exciting thing has happened over the past few months through COVID, and that is that people of color are now seen as full human beings. And I know it sounds weird, but
how did COVID bring that out?
Well, I think in terms of actually seeing the number of people that have been killed by the police, the violence, George Floyd's film was very, to see someone who was alive and then dying was, hard for a lot of people, because it's a human, it's a human being who's this is happening to. And so I think with, in medicine, I do think we have been, we are treating humans, and I think the programs that Skin of Color Society has is to work on education, mentoring, and research. And so research in clinical trials, and efforts are made to develop more physicians of color who can get these experiences, through the education, through research experiences, and through mentoring. So the efforts that were made in Mississippi to bring people who've grown up there, I think Dr. Byrd is an excellent example of, if you can recruit even your patients who, into medicine, there's a good chance that they will go back to that area or a similar area to practice, because that's the life that they know. So that's one of the things that the Skin of Color Society really works on, is the pipeline into medicine. And we start early, but there are, we really encourage young people to get experiences in medicine and in dermatology in an effort to eliminate this particular health disparity.
Right. You mentioned George Floyd. There's a monumentous cultural moment where a lot of people are trying to be aware of their own implicit biases. Are there things specific to the skincare world, which even for non-medical professionals, everyone has dealt with, skincare in some way, that people could be more aware of some of the biases, either in the products, in the marketing, in the medical care they're receiving?
Yeah, I haven't been able to bring myself to look at the video again, really, but there are color changes in this man as he's going through this. So if you can start in terms of even diagnosing or using products, or, if you can see that these products are, affecting the change of color, if you can see that the product is, the patient comes in and the doctors will say frequently to people of color, well, I don't see anything there. And the patient says, well, no, it's red. It's completely red here. It hurts, it's painful, it's warm. So the patients, of course, need to be touched. And I think that's a sensitivity that we have to start learning to look at the differences and understanding, and it's okay to be different. We're all different, you know, and we're all so mixed with many different ethnicities that we're going to be many different shades of color. And so I think it's important to be able to recognize disease and take many opportunities. Physicians should really, there are a lot of courses, Skin of Color at the American Academy of Dermatology. The Skin of Color Society has a symposium. It was just the Skin of Color update this weekend that was very good in terms of learning about how to diagnose and recognize problems in skin of color.
It's striking to me that that is its own symposia or curriculum, as opposed to simply being the baseline of what people are taught in medical school.
Yeah, and I think
is that changing?
Yeah. That's changing, and I think the medical schools have tended to not teach diseases in all skin types. And it is very important to, you know, even a patient with thyroid disease, you know, to see what it looks like in somebody with brown skin. So the schools are really, I think, making an effort to change, and that's been going on for a long time. That's not something that's just recent. The efforts, because the population of the country is really changing, and depending on what areas you're in. I mean, in Washington, you know, we just see patients from all over the world. So it's you know, training here, you get that variety of skin types and cultures. The important thing also is to understand that you know, the skin colors, that's fine, but there are so many different ethnicities with the same skin color. And it's really important to learn, as a part of medicine, cultural differences, you know, so that you don't give gel capsules to someone who is Muslim because they contain pork, and you know, that's not to be eaten. And people just throw them in the trash. So you wonder why your patient's not getting better. So I think learning different cultural things, learning what to say to people about their culture. And of course you're not going to know every culture that comes in your door, but you can learn from the patient, and the patient can learn from you, you know, about your culture too.
Right, right. I see culture intersecting quite a lot too in terms of skincare and wellness practices, where cleanliness and hygiene generally, where people have vastly different approaches, and that if you don't ask, which we tend not to, you don't ever find out.
Right.
We have one audience question to close, and it's from Susan Fendel. Disparity occurs for clients with mental health diagnoses. I have clients whose symptoms aren't taken seriously and are attributed to their mental health. One client saw 4 doctors for itching before a teaching hospital diagnosed her with a bacterial infection. So how can clients approach dermatologists to shake loose implicit bias toward people with psychiatric diagnoses? So not explicitly about
that's a very
racial inequities, but there might be some overlap in terms of addressing implicit bias.
Yeah, that's a very, very good question. I think talk too with the bias, we left out gender, disabilities, sexual orientation. There are many different besides the race, and that wasn't, but the mental health illness is a big issue, because the cell, the embryological cell of the skin and the brain come from the same source. So there's a lot of cross-reactivity with mental health and dermatology, and you know, a patient who comes in with itching and no rash it's a serious problem, and it has to be addressed, and they have to start looking for something internally, the dermatologist. There are people who come in with mental problems that present as skin, people, let's say, with delusions of parasitosis, who think they have bugs crawling. Those patients even deserve a good workup to make sure that they don't have cancer, internal cancer. Cancer, really lymphoma particularly, will present with a lot of, we call it pruritus, but a lot of itching, deep itching. And so you want to make sure patients don't have other symptoms. But there is a very, as Dr. Fried said earlier, with the depression, with diseases, with psoriasis, acne, eczema, is a very close connection, and you just can't ignore it. And I think this brings me to the point also about dermatologists really are the doctors who treat the whole patient. I was at a makeup counter and buying some lipstick, and this woman said, "Oh, well, you're a dermatologist." Oh, so she, and I told her, she said, "Well, how'd you get to be one?" I said, "Well, you go, medical school." She said, "Oh, I didn't know dermatologists went to medical school." Mm-hmm. So I hope she's on this this call, because I think this is a group that I'm really that are really taking care of some very sick patients, and I'm really proud to be a part of all of this.
Yeah. Well, that's a great note to end on. Dr. Lynn McKinley-Grant, thank you so much for your time and for the work you're doing, and for joining us today.
Thank you.
And last but not least, we have one more session. Please welcome Sharon King, the Executive Director of Liddy LIGO, which is a Boston-based advocacy network that helps raise awareness around vitiligo, to tell us her skin story. Sharon, over to you.
Thank you so much, and thank you for having me. So I have vitiligo. Shocker, right? It all started one fateful day in 1999. I was 12 years old, and 7th grade was a blast. I developed a bone color patch right below my left eye. And it was very visible because I have very rich, dark skin. So let's take a step back. My family moved to a town that wasn't very diverse. So before vitiligo even came into the picture, I had already had issues with my skin. I had a best friend who was white, and we planned to get married, but his mother told him we couldn't get married because I'm Black, and I was devastated. And I remember I started wishing to be white because, I was ridiculed. I didn't fit in that neighborhood. And we actually moved to a more diverse neighborhood because of that. So back to 1999, when I went to the dermatologist, he took a scrape sample. They confirmed it was vitiligo. And I thought it was my fault. I said, I did this to myself. I wish to be white. Now my skin is turning white. And that is something that, was I 12? You shouldn't really be having those thoughts, but, it is a product of this society. And again, I thought it was my fault, and I was really serious about that. And the doctor prescribed ointments and creams, and my skin didn't really respond. So we stopped doing those. And the next step was the light treatments. And I wasn't a fan of that because I was on the basketball team, and I didn't want to take away from what I was doing. And I asked the doctor, I remember asking him, is vitiligo going to affect my health? And he said, no. And I said, well, and this treatment, is it going to, alter my skin? And I guess at the time, the side effects were still changing the composition of your skin, and then your normal skin being very dark. And I didn't want to have to deal with that too. So I opted out. But the dermatologist was very adamant, and I remember my mother having to step in and being like, listen, she'll try it if she wants, if not. And I made an appointment, and then I'm like, I don't want to do this. I really don't feel like I needed treatment. And like, I remember my mother also being very calm at the time when I was diagnosed with vitiligo. And I was like, how is she calm? My life is over. My skin is changing. How is she so calm? And then, come to find out, my dad has vitiligo. My sister had vitiligo. A lot of women on my father's side had vitiligo. So this wasn't anything new. So for me, I wasn't really treated differently. And my parents were very much, you're a beautiful girl, go do that. My friends were very supportive. My whole, school career, I had really great friends. And I tell my friend, his name is Christopher J. Brookins. I say, I'm going to tell the story whenever I have a platform. I was in the 6th grade, 7th grade? No, 6th or 7th grade. And Chris Brookins was on the basketball team. And this guy, he was popular, he was tall, all the ladies loved him. And one day, some people were making fun of me. And, you know, I was pretty much a shell of myself at this point, being an adolescent and trying to navigate these feelings about myself and my skin. And, you know, he interjected and he said, you know what? Sharon is going to grow up. She's going to realize she's beautiful and she's not going to pay any of you guys any mind. And I was just like, the most popular guy in school said that to me? Like, I must be this person that he's talking about. And so, you know, I just decided to be that person. I said, you know, I may not feel all the way secure, but that's what I'm going to put out there. So I did feign confidence for a long time. And it was an 18-year process of grief, I guess you can say. I mourned the loss of my skin, and I had to get to a place of acceptance and realize my skin has forever changed. It's not going to go back anytime soon. And my skin has changed a lot. Like, as you can see now, I have virtually no vitiligo on my face, but there have been times where the vitiligo has taken up more than 70% of my face. You know, and so in 2017, my vitiligo had pretty much retracted, and I started getting spots again in the center of my forehead. And I'm sitting in my car and I'm like, oh, look, spots. Well, I guess that's cool. And I realized for the very first time ever in 18 years, I was not upset. I was not worried about how it spread, what it was going to look like. And it just felt amazing to finally be at a place where I can love myself unconditionally. So soon after that, that's when I started my Vitiligo organization, which is an outreach and advocacy network where we empower people that live with vitiligo and educate people and their loved ones that don't. It was new for me because I have never been one of those, I guess you can say, support group people. Like I had never, you know, in my time, I coped with avoidance. I didn't talk about it. No one else talked about it. If you made fun of me for it, you know, I learned how to, you know, develop a tough skin. So either I'm making fun of you back or I'm ignoring you, you know? So it was one of those things where I never really looked. And the one time I did look for support groups back then, there wasn't really much out there. I mean, internet was fairly, not new, but there wasn't really much out there for, you know, some vitiligo support when I was younger. So I started Vitiligo, and I would love to tell the story of Miss Tony Stewart. Tony Stewart was one of the first people to join Vitiligo. And after giving birth to her first child, when she was diagnosed, there was a big move, and she had a lot of stress, and her vitiligo spread aggressively. She sought treatment, and her doctor told her it would get worse before it got better because of her type of vitiligo that, you know, spreads. And so eventually she decided to forego treatment. However, the mental health aspect of living with vitiligo was, you know, it was devastating for her. She was a bodybuilder, and she stopped bodybuilding because of her vitiligo. And when she joined the group, I like to share pictures of people that that are not just have vitiligo, but are living, not just existing. You're living, you're doing things, you're going out into the world, you're seeking after the careers that you want to go after. Like, my biggest joke is, you know, I wanted to be on the Wheel of Fortune. And I always thought I couldn't go because of my skin. And so when I started Vitiligo, I said, you know, I'm going to audition for Wheel of Fortune because it's my favorite show. It's my favorite game show. I'm going to audition. I'm going to go. That's one of the things that I want to do that I let my skin hold me back from. And so these conversations, these interactions, and being with people who understand, being with people that know that there is no one right way to heal. You can seek treatment. You don't have to seek treatment. It's up to you. You can cover up. You don't have to cover up. It's completely up to you. There's no right or wrong way as long as you're not harming yourself. Tony has, you know, she's one of my favorite people. She posts pictures all the time now with her coined phrase, cool beans. And, you know, I get messages like this all the time, you know, whether it be from a post or someone's testimony or one of the events that we do. People are learning to live with this. They're learning to advocate for themselves and what they want when it comes to their skin, and learning to live for themselves, and not just behind the opinions of what others might do or say. I'm a community outreach and advocacy specialist for the Boston Center for Independent Living. And this is an organization that was created to champion for disability rights. And I often speak with medical students and I tell them about my experience living with a, being characteristically unique, as my friend calls it. And I love the conversations because they realize that, vitiligo may not affect your health, but that mental health, it's traumatic to live with vitiligo. It's very traumatic. A lot of people make it look easy, but that didn't come with a lot of work. So I guess I'm going to close out with the Instagram post, if we can put that up, right? I don't know if it's up, I can't see. But yeah, so I I put up oh, there it is. So yes, this is a post that I put up the other day as Facebook reminded me that 2 years ago, this is what my face looked like. And I was like, really? Okay. And I really felt the need to post. So I'm going to read this for the people that are on the phone or that need the audio. I never thought that I would be in a place where I would miss the vitiligo on my face. For me, vitiligo is my natural makeup. I don't need it, but it does enhance my features. I can do without it, but I love the person that I am with it. Back in July, while on the Houston Vitiligo Awareness Movement community call, I hosted an activity where everyone gave their journey a name, and one gorgeous woman referred to hers as a roller coaster, and I felt that. My vitiligo was the ride that scared me, and I never thought I'd have the courage to face. Once I started talking about it and processing my feelings, not only toward vitiligo, but myself, that was me boarding that ride. That creep up to the drop, that no turning back, here we go into vitiligo was so scary. But now that intimidating feat that made me put my head down and walk past is now my favorite ride in the park because I own that thing the way I own my beautiful skin. I am in a place where I do not only love myself unconditionally, but I can teach others to do the same and advocate for themselves. Doing the work has granted me access to many rooms and opportunities like this one. And this is an incredible feeling. Thank you so much for having me. And that's what I have.
Well, thank you so much, Sharon, for sharing your personal story and for making it your mission to educate people. And thank you to all of our speakers today and to all of you, our audience, for tuning in. And thanks again to Pfizer for supporting the Atlantic's journalism today. And before you go, we want to let you know that the Atlantic Festival is going virtual this year, and it's coming up next week. Tickets are free and open to the public. We've announced our lineup of speakers, including Dr. Anthony Fauci and many other leaders in healthcare. You can learn more on theatlanticfestival.com. Thank you for watching.